Now we're live. Great. Hello, everybody. Welcome to our second episode of MedLink Global Rounds. My name is Ren, and I'm CEO of MedLink Global. Today, I'm very excited and thrilled to have this discussion with two remarkable leaders in the field, Mark and Christoph. They are also my strongest supporters here at MedLink. We were exploring the critical challenges and innovations in mental health assessment today, which we truly believe is fundamental for every aspect of patient care. But before we dive in, I would love to have both of you, two distinguished experts, to introduce yourself a little bit, especially to the audience who might be new to mental health or medical field. Christoph, maybe start from you.
All right, yeah, my name is Christoph Corell. I'm both an adult as well as child and adolescent psychiatrist. I'm professor of psychiatry at the Zucker School of Medicine at Hofstra Northwell in New York. And I'm also professor and chair of child and adolescent psychiatry at the Charité University in Berlin. So I straddle both continents, often mid-air. I can be found either sleeping or working. And I've been really drawn into psychiatry because of the mind and the brain and trying to understand life, myself, patients, people around me. And for that, asking questions, but also having the proper assessment is crucial. So throughout my career, I've also developed certain rating scales, I've validated them, but I'm now really excited to work with MedLink Global and you, Ran, and particularly with you, Mark, who I hadn't known before, and true expert in having thought through how do we actually ask the right questions? What are the dimensions we need to figure out? Where is the transdiagnostic landscape where we can place ourselves when we have either interest in who we are as people, but also where our patients are? And crucial to MedLink Global and the discussion today, how do we weave that into a very busy schedule where we have too many patients and too few staff members to actually assess them? But Mark will solve all of that for us, both at MedLink Global, but also during today's session. And maybe, Mark, you can introduce yourself, and then we'll have a great discussion today.
Thank you, Christoph. So I'm Mark Blaze. I'm a clinical psychologist. I'm the founding director of the Psychological Evaluation and Research Laboratory at Massachusetts General Hospital. We call it the Pearl. The Pearl provides comprehensive psychological neurocognitive evaluations for adult patients who are suffering from complex psychiatric disorders. My career over 35 years has focused on understanding and improving the utility of commonly used psychological tests, and more recently, in the last 10 years or so, trying to translate the emerging empirically based dimensional models of psychopathology into viable, useful, easily accessible clinical scales. It's been an ongoing challenge and one that I believe that we at MedLink are going to be able to overcome quite positively. I've been actively involved as a practitioner doing psychological evaluations. I trained psychologists for over 30 years, and I've had an active research program. I've developed multiple scales. Some are available but for purchase at national companies, and I'm very glad to bring my research and clinical experience that includes working with business, hospitals, mental health clinics, and athletic programs to MedLink to help create this diagnostic system.
Wonderful. Well, thank you so much both for sharing your career path. As leading experts in this field, we can see, and who also work and teach and practice in top universities in the world. Uh, in your daily work or daily schedule, what would you say is the most critical challenges in actively diagnosing and effectively treating people with mental health conditions?
All right, why don't I start off? I'd
Yes.
just like to say that, the two are intricately codependent, that without an accurate and fairly comprehensive initial assessment or evaluation, it's going to be hard to implement any kind of effective treatment and monitor that treatment over time. So diagnostic efficiency and treatment go together. There are some practical limitations at the diagnostic end, and these primarily include time and training. There really isn't allowed in the system enough time for individual practitioners to really do a comprehensive evaluation. In fact, usually it's a 30 to 40-minute initial interview that results in establishing a diagnosis and informing treatment. The second part, and that certainly isn't enough, but the second part is also training. Emphasis on diagnosis across and within the mental health fields varies substantially. And even in psychology, the last decade has seen a major decrease in emphasis on assessment and diagnosis and a more prominent focus on treatment. So those are some of the practical problems. But for me, what I see as sort of the biggest obstacle to this is the mindset of many of our mental health professionals, that we continue to view psychiatric mental health problems as being individual disorders that have their own unique symptom packages. And that when you evaluate a patient, you try to sort those symptoms into their categories. And once you've identified a categorical disorder, you're kind of done. You believe that the evaluation is over and that's the difficulty or the problem that you're going to treat. Simply doesn't match clinical reality. Patients have multiple disorders. Comorbidity is rampant in the mental health field. So trying to get the field to move beyond symptoms and to reconceptualize mental health evaluations as being more comprehensive, that's really the change that needs to happen.
Christoph?
Well, wonderful, Mark. I think time, training, the overlapping dimensions, and lack of precision, I can only underscore all of this because we are really in a difficult place in psychiatry. We don't have biomarkers of the illness. We have more disorders than symptom domains. So there's all of this overlap. And we have no good understanding which treatment is specific for a diagnosis. We treat symptoms more than diagnoses. Clearly, symptoms cluster to syndromes, and then these syndromes become diagnoses, how we currently classify them. But we all know all models are wrong, some are useful, and hopefully over time, some of these models will evolve and have some biological legs to stand on. But until we're there, we need to at least have a comprehensive assessment of patients. And the comprehension is not there in terms of broad clinical use. We don't have the time, we don't have the training, as you said, Mark, but we also don't know what to do with this information. So conceptualizing it like you have done and getting it from a pool of questions so that we then get color into the patient or the individual, understand this better, and also have red flags that hopefully, as MedLink and you are trying to do this now, can be easily also transmitted and communicated to patients and clinicians. What is the red flag? Where is the fire where I need to put some water, and which water is needed for which condition? We don't have that at the moment. It's a lot of gut-based psychiatry. Oh, I've done this for 30 years. I've seen patients like this. I give X, Y, or Z. But having a true problem list that is informed by a comprehensive self-assessment and maybe even AI-driven comprehensive assessment that is then spoon-fed or at least given to clinicians and patients that they can act upon and not waste and spend the half hour or hour and a half to get the data. That's, I think, where I want us to be and where I think MedLink, that's why I joined MedLink, can bring us.
Oh, thank you so much. I completely resonate with you guys, not only about the issue part. We know, we all agree the status quo is inadequate and even not acceptable for both clinicians and patients. But if, continue your conversation, that's the ideal way of processing the patient information. Mark, since you mentioned we can do it in a more comprehensive way and more kind of connected way, we shouldn't see symptoms alone or even disease alone. Can you explain what is like your ideal, or what do you believe the right model, the preferred model of seeing psychopathology?
So the preferred model, I'm not sure they're right now, like Christoph said, there's so many things that we don't know in the field that right is really not what we're shooting for. We want a more efficient, more effective model that then can be replaced by something even better. But I really want to focus on the word process. The diagnosis is not a one-time event. It doesn't just occur. It really is the process of continually collecting information, organizing it, and then applying it to the ongoing care and monitoring of the patient that you're treating. So, but what would make the current system a little more ideal? Well, I wish it would be efficient, that there would be a process in place where, without being too burdensome to the patient and without taking a lot of time from the clinician, a more structured or a more organized evaluation can be undertaken. It should be a reasonably comprehensive, and I say reasonably comprehensive because nothing's going to be comprehensive, but we do know the symptom space for the most common and the most severe psychiatric disorders. So any evaluation process or system needs to take the broad view and cover all the symptom space of the most common and most important disorders. It really should be empirically based. We shouldn't be continuing to rely on consensus agreement of committees. We need to transition away from that and move into a more empirically based method. And one that does more than just align symptoms with specific disorders. Because at the end, you can have a bunch of disorders or a bunch of symptoms, but really no integrated picture of the patient's status. So efficient, not burdensome, reasonably comprehensive, empirically based, and with an organizational design that's more actionable than a standard psychiatric or mental health evaluation.
Yeah, and that sounds to me is dimensional transdiagnostic model of psychopathology. So, and that's part of our main theme today, to letting people know more about it, what is based at why it's better than the categorical traditional model, and how we can really leverage it to daily clinical practice. Can we dive in? Let me share something to the audience, and then maybe Mark can start.
Yes, this is what's really exciting to me. This part of it is really exciting to me in that we've known for years, the research all supports the fact that psychiatric disorders are very comorbid. That is, people who present for treatment almost never have a single disorder. They have multiple disorders. And the multiple disorders occur in patterns. They're not random. And that's called comorbidity. And for the long time, research attempted to treat comorbidity as the problem and to remove it from the diagnostic system. But about 20 years ago, that changed, and we began to really focus on what disorders had in common. And by doing that, we discovered empirically that a host of the most common and severe psychiatric disorders could be reorganized into a dimensional model where three broad categories captured most of those disorders. Next slide, please. So here's the reorganized disorders, but you can see these have things in common. Depression and anxiety co-occur. Social anxiety co-occurs with depression. PTSD, anxiety, depression co-occur very often. Alcohol, drug abuse, impulsivity, antisocial behavior, they all sort of coalesce together. Psychosis, paranoia, mania, grandiosity, those are the more severe disorders. And when we reorganize them empirically, we get the next level. We see broad categories or dimensions: internalizing, which is really the emotional dysregulation that we see; externalizing, which is behavioral dysregulation; and thought impairing, which is the disruption of logical or realistic thinking. And interestingly enough, when again empirically we look at the relationship of the large dimensions, we see that those two are interrelated, and the three can combine to create an overarching global measure of psychopathology. Please. Yes, global severity. And when this is using the current symptom space, we're not introducing anything new. We're not asking you to learn anything different. We're taking the same symptoms that have been identified as important and placed in the DSM, except we're allowing empirical methods, mostly factor analysis and structural equation modeling, to identify the patterns underneath the disorders. And this is what we see. And this has been replicated across multiple samples in multiple countries using different types of measurement: symptoms, disorders, self-report, informant report, and with cross-sectional or longitudinal research design. So the model is very robust.
Christoph, do you think this model and how much it can capture the complexity of mental illness can be bring some key advantages of the daily practice to clinicians?
Yeah, so regarding assessment and treatment of mental disorders, I have a dream. And that dream is measurement-based care, where the measurement happens outside of my visit with the patient, where I get this in an organized and structured way, and I know that there are certain internalizing clusters that are a problem, or externalizing behavioral, could be also compensatory behaviors, with or without some cognitive and thought impairing behaviors or conditions. And with that, handed to me with both the extent but also the severity, I can then design a treatment plan and focus with the patient on these things that the patient has outside of my visit said or scored, because we don't have enough personnel, we don't have enough mental health practitioners to actually bring that information into my hands and into sight so that I can discuss it with patients. We need to also make sure that we have shared decision making and that we are working with patients as partners in co-developing treatment plans. And they will also be much more informed partners of devising treatments when they have like a map, a roadmap of who they are and where they want to be, and where there may be a distance, which then also hopefully resonates with them. Yes, that's true. I don't have friends because I am anxious. And maybe that's something I want to work on so that I can reach my goals. So I think it's very important that we have psychopathology, dimensionality, severity, but we should not lose sight of functional goals and functionality. That needs to be part of both the assessment, but also the goal setting with patients, so that we then have a comprehensive treatment plan.
That's amazing. And I think we have a good news for you, that your dream can come true with this. How about Mark? Can you maybe share one real true story about how, any success story about how these kind of model and what Christoph just mentioned, we capture all the information and put into diagnose and treatment decisions, and the catched really nuanced and personalized plan for real patient.
Well, I certainly will have that kind of vignette in a moment or two, but I want to get back to some of the things that we were talking about. We throw the word transdiagnostic out a lot, and what that really means is that we're combining related disorders. The transdiagnostic evaluation sort of happens at that second core dimension level. That's what makes the model transdiagnostic. And dimensional measurement has always been shown to be more superior to categorical measurement in terms of capturing information and more precise in its measure of distress and dysfunction. And so by moving to this transdiagnostic dimensional model, not only do we get layers, multi-level layers of information, we get more precise information. And the dimensions are not separate from normal behavior. In fact, the internalizing dimension would encompass sadness and disappointment just as much as it encompasses severe depression. So the model doesn't put the person that is being evaluated into a different class. They're still suffering from problems that are part of normal states of living, but at the extreme end, most likely. The model helps us with, by doing this, it helps us with subclinical conditions, and it helps us with the high comorbidity that we have. So, for example, now I've been working this system with various instruments for about 10 years now, and I keep being surprised by the insights that it can bring. But recently, I was evaluating a young man who was having trouble finishing up his college degree. He was in his 5th year of college, and he had not made a lot of progress. He was being treated for severe depression and ADD, but he was being more irrational and more withdrawn. He took a leave of absence. He came to the clinic for an evaluation. Included in the evaluation were procedures to get the transdiagnostic information or the information arranged that way. So in evaluating the patient, we were able to see that starting at the top, global severity was far in excess of what is typical of an outpatient. So immediately there was an indication that either more frequent sessions or more intense sessions or a higher level of care was going to be required to initiate treatment. In addition, it indicates that treatment's going to be long-term. And in fact, might have a level of chronicity that means relapses, reoccurrences, and response remissions, but treatment's going to need to be ongoing. When we move down to the dimensional level, the core dimensions, for sure, there was intense internalizing emotional distress, clearly met criteria for depression and anxiety and social anxiety. But staying at the core level, we were able to see that there were also moderate elevations in externalizing behavior and mild to moderate in thought impairing behavior. When we looked within those dimensions, there was a budding or an emerging substance use problem, probably to deal with some of the emotional distress, but also he elevated a moderate elevation in manic activation, which is unusual for somebody who has severe unipolar depression. So reviewing his history, he'd never been diagnosed with bipolar disorder. He'd never had a manic episode, but in discussing with his family, he had had a couple of episodes of agitated depression. So there were a couple of times where he was depressed and actively irritable and still, more energetic than expected. And it turned out that he was having a mixed depressive and hypomanic episode. And by doing this, we were able to help the treaters shift focus from mood stabilization and to stop giving ADD medicine and to focus more on mood stabilization and to initiate an evaluation and treatment for substance use. So it really sort of shifted the focus of the care and brought to light subclinical features that were causing this to be much more impairing and much more life-changing than was thought.
Well, thank you for sharing. That's very insightful. And Christoph, would you have any more question or add anything to the application of this model?
Yeah, let me add something from actually a MedLink Global experience. We have obviously a system where clinicians can refer patients or patients can self-refer, and then experts that are part of our network that we select then evaluate the patient. And at that time, we didn't do it AI based, which we've now evolved into. It was a psychologist who did the interview and interviewed the patient and then also the parent. And something was off. The patient wasn't doing so well. The mother was very concerned. It was a very murky and irky picture. But when then this girl basically filled out the questionnaire that Mark devised, there was such a cluster of PTSD symptoms, which she had denied flat out to the interviewer, but it was right there. The paper, she just told everything to the paper. And I was able to then actually get to it, that there was something that was really traumatic for her that she had hidden from her parents, from also other healthcare professionals. One psychologist had seen her in one session, said, "Oh, you're healthy, nothing is wrong," because she's sealed over. But with this comprehensive assessment, where these questions are not coming all at once, they're scattered, and the patient might not notice it, that this really stands out over the other components of her mental functioning, I was able to see this better than I would have even done it in an interview, because she would have denied it for me too. So that really sold me to the very dimensional assessment, where it's then afterwards put together again and was very clear there is something I need to follow up on and then also treat.
Yeah, now since you said, I remember now that was a quite unique cases, right? I can't believe something can be overlooked because the hesitation or any reason for years, and can be really stand out through our assessment, that eventually we could help her indeed. Since you mentioned AI, let's move on to AI, a new era that has been changing really our lifestyle today. But our focus today is mental health assessment and evaluation. So my question to both of you is, how do you see we can leverage this such powerful new tech? Can we have AI enhanced or AI augmented assessment system that we have been building on, and how that can address the current limitation of traditional assessment and diagnosis?
Who would you like to throw it to?
Mark, go ahead.
All right. And again, I would just like to follow up on something from the last part of the discussion, is that sometimes people are more willing or able to share something when they're taking a test and they're not in the presence of another person. Sometimes that's the case, but very often people can't organize their own inner experience with the same clarity that is needed. You say, well, rate your depression on a 1 to 10 scale. People don't really know what to put into that. But when you have a questionnaire, a diagnostic tool that lays out these very specific and clear questions, and then compares your responses to a nationally representative sample, you can quantify that easier for the patient. I'm really excited about AI. I am learning more and more about it every day. I come from almost no background in it, and this is one of the really exciting aspects of joining MedLink. It's the frontier, the new frontier for mental health. And you can see with the papers that are coming out that people are kind of looking around for ways to apply it with existing information in medical records and automating parts of interviews. But I believe there'll be a lot of advancement through AI. Modern psychological assessment began in 1905, and we've improved it and refined it, but there haven't been any real major advances in what we've done in at least 50 years. We rely heavily on statistical methods like factor analysis and multiple regression and structural equation modeling, which are very powerful, but have limitations. We know that psychiatric disorders, problems in living, come from a very complex interaction of genes, experience, developmental problems, the environment, and we're not sure how that all works together. even the things that help us be resilient. We don't know how that all goes together. And I think that through AI, we're going to have the potential to see more or to have a deeper understanding of all those interactions. At the immediate level, it gets back to the questions that you asked at the beginning about what are the limitations. AI will immediately make the interview more standardized. It'll allow for example, our idea is to have AI take the information from the profile, the mind's profile, and then do an interview with the patient based on that to find the functional impairment, to see where in their lives these difficulties are having the impact, and to get their own phenomenological experience of their condition, and then to organize that into a way that can be handed off to the psychiatrist or social worker or psychologist that as usable, actionable information. That's sort of how I see AI has incredible promise that I can't imagine, but hope for, and immediate application that will make the field much better.
Yeah, I couldn't agree more. And for our purposes, I mean, AI has been translated into many things, artificial, automated, but I want to recoin this for our discussion and intents and purposes as all-inclusive and all-informed. Because, as you just said, Mark, when the patient fills out the mind's assessments, and that is then handed to the AI agent, it's an informed interview based on what the patient already has said and filtered, and then it's all-inclusive and goes into all these recesses and gets the information needed in a very conversational and also empathic way, giving the patient a lot of time where there's no rushing. It's not like in a clinical setting where they may be uncomfortable or have to rush back home. And with that information that is then distilled and again visualized, I as a clinician can do much better assessment and care. And that's, I think, where we need to go.
Right. So for those audience who are not familiar with minds yet, we have been built this assessment system called Minds. It has two components. One is the assessment part, which we will go through a comprehensive questionnaire that catch the things, as Mark and Christoph said, may not really pre-organized inside you, and you won't present it in your doctor's office immediately. And after that assessment, the AI interview is the second component that catch more detail and also save a lot of time that we all suffer from, patients and clinicians today, so that, after no rush interview and the detailed interview, everything will be all inclusively packed together and handed to the provider hand, so that before they even see the patient, they already have a decent number of information about this person. Anything else to add, Mark, before I share exciting news to our audience?
Well, one of the things we talked about, what would be some take-home for the audience, key take-home messages. One, if you're an individual seeking psychiatric care, mental health treatment should be based on a more comprehensive assessment. So try to seek out a good assessment. If you're in care that seems to be underperforming and you don't seem to be getting the progress that you want, think about asking for a consultation, getting a second opinion, and including psychological instruments, comprehensive evaluation in that way. For practitioners, I just want providers to recognize that the mental health field needs to change, and we've sort of exhausted the utility of the traditional system. We're not having any big breakthroughs. We're not getting any additional treatment efficacy at this time. And so if we change or reapproach diagnoses and treatment development from the Transdiagnostic model, we're not throwing away anything. We're keeping the same symptom space. We're just reorganizing it and being able to act on it at various levels. There are research now showing that the core dimensions have a stronger relationship to biological processes, to genetic factors than individual disorders do. There's a growing relationship between, again, the core dimensions and neuroimaging findings that has been elusive in looking at disorder specific studies. So just consider adopting a change of outlook that will allow you to keep your familiar syndromes and your familiar experience-based treatments, but move forward with a more empirically based model of psychopathology, mental health, and mental illness.
Well, thank you for sharing that. Yeah,
Yeah,
Christoph.
maybe just a couple of sentences that bring in some of the questions we've been receiving both before the program and now. Obviously, this will not give us total insight into where each disorder is coming from, what the connection is between genes and cells, and from cells to behavior and behavior to treatment. But minds is a play on words. It's minds with an AI in the middle. So through AI, we're trying to shed more light from within the patient themselves, but then also from outside with a comprehensive assessment into the phenomenology. And the phenomenology, which then clusters based on the experience we have with disorders around certain conditions, which can then be leveraged in terms of, is psychotherapy good for this, and which psychotherapy, which medication could be put into this. And some questions were, what's novel about it? Istvan Bitter asked that, for example. Well, I think, as Mark said, it's basically having these three streams of expression of humankind, which is much more organized now, which gives us actionable precision psychiatry fodder for our meal with the patient, and that we can really drive home and then also adjust based on further assessments down the road. And what are implementation issues? Well, not everybody will have access to Minds. It will have to go via MedLink Global. There might be other programs in the future, but we will replace very inefficient systems where we don't even have psychologists do these assessments, where clinicians are worn out and overburdened, having to ask the same questions over and over again, gathering information rather than using the information in order to do the treatment planning. That's what we're there for. We shouldn't be collecting like squirrels all the nuts. We should have it all, the nuts and bolts in a place in order to then do something with it. But I know, Ren, you have something you want to actually share with the audience, so that I stop rambling here and give some value back to the audience.
Thank you so much, Christoph and Mark, for sharing all this benefits, and that's how we really address the limitation we were talking in the very beginning, the limited training and time. Here, I'm having this slide on. I see a QR code. I would love to take this moment to share this exciting opportunity to all the audience. We're launching a limited beta program for Minds. We have been talking about what's Minds, and we want to invite some of you to be our first users of Minds. Scan this or share this code to whom you may think can benefit from Minds in terms of, advancing diagnosis of mental health. And we will work with you to, as a beta user, give you the access for free, and we will work with you to customize it to your specific practice. And additionally, and which I see as the most valuable in this package as a beta user, is you will have direct access to our network of leading experts such as Christoph and Mark whenever you encounter a complex cases through, using Minds during the trial time. Yeah, we're really looking forward to working with you guys. Before we say goodbye, I want Mark to also update us, say a few words about Minds and what's coming up after Minds. And Christopher will share our next month's topic after Mark.
All right, thank you. Thank you, Rand. Uh, Again, I seem to have to follow up all the time, but to say what is unique is really the most unique aspect of the transdiagnostic model is that overarching P factor, the general psychopathology factor, which has not really been something that people have thought about consistently or systematically before. And it really has the power as a single global number that helps with severity, treatment intensity, and prognosis. If it continues to live up to the research findings, it'll be a remarkable advancement for clinical practice. Now, the project that we have, MINDS, is still being worked through. We're in the beta phase, but we're beginning to field test MINDS 2, which is going to be for personal understanding. It's going to focus on normal personality, normal psychological traits, and provide individuals with feedback about their personality, things that they might have problems with, areas where they are the strongest, if they have particular questions, what would be a good career, or what kind of person might I want to have a relationship with. This is the kind of information that we're expecting MINDS 2 to be able to deliver to anybody who is interested in knowing more about themselves or knowing more about their partner or friend.
That's very exciting, right? Um, okay, I know we have 1 minute, but Christoph, can you tell the audience we are having a March every month, but coming up March, what's the topic of our webinar so that they can block their calendar?
Yes, so it will be basically the 17th of March, Monday, and same time, 2 p.m. Eastern, and we'll have innovations in the treatment of psychosis. So the third column where it was about thought disorder, what's new? There are new things, and I'll be joined by two experts and friends of mine, Leslie Citrome and Jonathan Meyer, and we'll go through all of these pharmacological advances and also how this is shaping our understanding of the brain in that domain. And I just want to say one more thing about what Mark said. I think MINDS helps us both with the P factor in coalescing everything into a metric of severity, but at the same time, it's a prism and gives us also the individual symptoms. It has both the handle and basically the branches that will help us help patients get more out of life and also formulate their goals where they can maybe make more gains together with us as healthcare professionals.
Thank you so much. Thank you both again sharing all your insights and knowledge with us. I have learned a lot in the past 1 hour, and I hope the audience has too. Um, Again, thank you for joining. I hope some of you, I'll see you in our beta program, and have a great rest of your day.
Thanks,
Thank you,
Rand.
Rand. Thank you, Christoph.
See you
Thanks,
guys.
Mark. Take
Bye.
care. Bye.
Bye-bye.